Thank you, Drs. Busvaros and Denson. I'd like to present our research looking at the efficacy and safety of 2 doses, higher and lower dose adalimumab. This is a sub-analysis of the study Imagine-1, which Jeffrey Himes was the first author of the prospective trial for adalimumab in pediatric Crohn's disease. The disclosures of the authors are listed. I'd like to add 2 of my own. The first is I do not wear a skirt. The second one is, while both Dr. Baldessano and I will never be a dinosaur, I am the same age as Bob, so anytime you want to do that cannabis study, I will be your age match control. It's South Florida, it's Friday night, what the hell? So as we've heard in that excellent debate, the true goals of all of us in treating pediatric Crohn's disease is to make our patient better and to change the long-term outcomes while maintaining growth and pubertal development. Adalimumab has been shown to be effective in both inducing and maintaining clinical remission in children with pediatric Crohn's disease of moderate to severe activity. And in fact, it has already been approved in the EU for the treatment of severely active Crohn's disease in pediatric patients ages 6 to 17 who have been refractory or intolerant to conventional therapy defined as primary nutrition therapy, corticosteroids, and an immunomodulator. As I mentioned, Imagine-1 was a 52-week randomized double-blind trial looking at the effect for both the induction and maintenance of remission in children ages 6 to 17 years of age with moderate to severely active Crohn's disease as defined by the Pediatric Crohn's Disease Activity Index of greater than 30 at baseline. It's the largest biologic trial to date in pediatric Crohn's disease, enrolling 192 patients. The criteria are listed, and I would add that the immunomodulator had to be stable for at least 8 weeks, and about 60% of patients enrolling in Imagine were on an immunomodulator at the time of enrollment, which reflects the tenor of the times amongst pediatric gastroenterologists, contrasting that to the REACH trial of infliximab, where pretty much 100%, or I think maybe 1 patient was not on an immunomodulator at the time of enrollment. In this trial, 44% of the patients had been prior exposed to an anti-TNF, i.e. infliximab, upon entry into the study. The 26-week outcomes were the primary endpoint of the original study, and what was noted at both 26 and follow-up at 52 weeks, a numerically higher proportion of patients who received the higher dose of adalimumab had achieved clinical remission compared to those who had received the lower dose, but these differences did not reach statistical significance, and those numbers are shown on the slide for both 26 and 52 weeks. We noted that in a subgroup analysis at week 52, those patients who were receiving adalimumab as their first anti-TNF had a higher rate of remission than those who had been previously exposed to anti-TNF, hence the mantra, your first kiss is your best, and you tend to do better with your first anti-TNF agent. This, for those of you who don't know the Imagine trial, this was the enrollment criteria, and I'd like to highlight what is meant by high and low dose. It was broken out by weight, with 40 kilograms at the time of enrollment being the cut point, and for those who were above 40 kilograms, they received standard adult induction of 160 milligrams, followed 2 weeks later by 80 milligrams. For those less than 40 kilograms, they received 80 milligrams, and 2 weeks later, 40 milligrams. This was an open label induction, and at week 4, patients were randomized into 2 dosing strategies, again, stratified by weight, with the 40 kilogram cutoff point as shown, but also on whether or not they had responded at 4 weeks, and they were also stratified whether or not they were anti-TNF naive or anti-TNF experienced. In those patients who were above 40 milligrams, the high dose was 40 milligrams of adalimumab every other week, and the low dose was 20 milligrams every other week. For those who were above 40 milligrams and receiving the low dose, that's 20 milligrams every other week, and for less than 40 kilograms, they received 10 milligrams every other week. For the original study, the primary endpoint was at week 26, and follow-up was through week 52 as shown. The aim of the present study was to evaluate the efficacy and safety of the 2 maintenance adalimumab dosing regimens based on baseline severity of the disease activity in children with pediatric Crohn's disease. The disease severity was classified as being moderately active in those patients who had a PCDI of less than 40 and severely active in those patients who were greater than 40. Remember, all patients had to be at least over 30 to even enroll in the trial. The endpoint of the current study was clinical remission at 52 weeks as defined by a pediatric Crohn's disease activity index score of less than or equal to 10. Clinical response was defined as a fall of at least 15 points in the PCDI from baseline. Clinical remission and response at week 52 was also stratified by prior infliximab use. Data analysis used the chi-square test to compare treatment groups, including subgroup analysis by prior infliximab use. We used a non-responder imputation where patients were considered being a non-responder if we were missing data, if there was premature discontinuation from the trial, or if they escalated to weekly therapy, which was part of the trial for those patients who were not responding to therapy. The data are shown here. First, we're looking at clinical remission at week 52. Again, this is defined as a pediatric Crohn's disease activity index score of less than or equal to 10. And on the right side, you see those patients who had severe Crohn's disease upon entrance to the trial, which means their PCDI was over 40. And you'll see there was a statistically significant difference in clinical remission rate at week 52 in those patients who had severe Crohn's disease. That difference was not seen, and in fact, the response rate was pretty much the same in those patients who enrolled in the trial with a PCDI of less than 40. Looking at response, which again was defined as a drop of more than equal to or more than 15 points in the PCDI over baseline values. Those patients who entered the trial with a PCDI greater than 40 and had severe Crohn's disease showed a statistically significantly higher clinical response rate when compared to those who had a moderate degree of, who received the higher dose of adalimumab had a higher rate of clinical response compared to those who received the lower dose, and that difference was not seen in those patients who enrolled at moderate disease activity, i.e. less than 40 of PCDI. Looking at the clinical remission rate and stratifying based upon whether or not the patients had seen infliximab upon entrance to the trial or not, we see a statistically significant difference in those patients who had severe Crohn's disease entrance and received high-dose adalimumab when compared to those who received the low dose. That difference was not seen in the patients who had seen infliximab before, nor was it seen in the patients who entered the trial with moderate disease activity. As in any study, we're very interested in side effects. The IMAGINE trial showed no patients with malignancy. There was 2 opportunistic infections. One is Aeromonas and the other is histoplasmosis. And the leading adverse events were infectious, which is not surprise in a Crohn's disease trial, with the majority of them being typical pediatric illnesses or Crohn's-related infections. So in conclusion, at 52 weeks, high-dose maintenance adalimumab was more effective when compared to lower-dose adalimumab for those children who entered the trial with severe activity, i.e. a PCDI over 40. Infliximab-naive patients showed the greatest remission and response rate as compared to those who entered the trial already being exposed to infliximab, and the SAEs overall were somewhat more frequent in patients who had moderate activity and received a higher dose than lower dose, but this was not statistically significant, and the overall safety profile was similar in both dosing arms. Thank you.